I'd like to thank Dr. Charmaine Green and PKD Australia to have this opportunity to talk to you tonight about this very important topic of pain in polycystic kidney disease. And this talk tonight is really about trying to get this topic discussed more and to really try and accelerate sort of developments in this area. And tonight I'm joined by Dr. Alister Ramachandran, who's a pain specialist at Westmead Hospital and has got extensive experience overseas and locally on the management of pain. And we're going to do this talk today together. And I've got the format of the meeting is going to be a general overview of the causes of pain, things to discuss with your doctor about the pain, some general approaches about treating pain, and then we'll finish off with a research project which we'll talk to you about. But I'd like to keep this meeting more open to you so we can answer questions that you've got, and our discussion will just go for hopefully 20 minutes or so, and we'll really just try and spend the rest of the time just taking questions from you. So I hope that's okay. So the overview of, I just sort of start off with some just general things, just to give you a bit of an overview on what the medical side is thinking about pain in polycystic kidney disease. And there's a lot that we've got to learn from you. I think our knowledge of pain in polycystic kidney disease is very, very incomplete. And as I say, it's really because we haven't had the conversation with you about this topic. So what I'm going to talk about is quite a superficial overview. And I think all of you in the audience are the experts. And so we'd like to learn more. And this is really just an introduction to this topic. So from the perspective of the medical side, we view pain in polycystic kidney disease as either being short-term, acute in onset, so an episode of pain that's less than 2 days in duration, something that happens in a short period of time, or alternatively pain from the kidney that's occurred for a long period of time, so chronic pain that's lasted either intermittently or continuously for over a month, 2 months, 3 months. And chronic pain is very common in polycystic kidney disease, as you know, and more than 2/3 of people will experience some type of chronic pain particularly after the age of 40. And we know that pain is a very disabling and problematic symptom. It's the main symptom that you complain of. It has a major impact on physical and social well-being. And we're only really touching the surface on trying to understand how it impacts people with PKD. Recent trials like the TEMPO trial, which used tolvaptan, gave us a little bit of insight on how big a problem this is. And in that study, they noticed that 1 in 3 people with polycystic kidney disease were using medications to deal with pain. 1 in 5 people had problems with sleep with pain. Huge impacts on physical activity. 20% of people at any particular time complained of difficulty with physical activity. It obviously, as we'll touch on later with Alister, affects social well-being, mental well-being, so therefore can impact work life, relationships, and a whole host of things. And Alister, did you want to make some additional comment? Oh, Alister, you might have to unmute.
Just like as we spoke, prior to we started this talk, recognizing the problem is the first step. And he said in the recent trials that pain has come up as one of the big factors in which they've identified. So I think patients with PKD should be sort of recognized by the treating health professionals, be it the nurses, from the doctors, the GPs, or even specialists, and probably refer them on quite early, because early intervention is key, because once they come beyond a period of time where it's over 3 months or 6 months, there might be a definite physical cause for the pain, but then it morphs into a whole bigger problem. It becomes more of a psychosocial issue because the physical ailment brings on mood disorders, depression, anxiety, physical deconditioning, loss of work, vocational aspects. So all these things fall apart. And it all stems off with a pain problem which wasn't treated in the early phase. If it was addressed very early, then probably we could have a better outcome. And that's what the main stress is. Can we sort of reduce that transition from acute to chronic pain? There's multiple studies in terms of persistent post-surgical pain, for example, after surgery, up to 30% of people do get persistent pain. So how do we sort of treat this or reduce the transition from acute to chronic pain? So they've tried medications and different injections and interventions, but what we know at current best standard is the only intervention which can prevent the transmission or reduce the incidence of transition from acute to chronic pain is appropriate acute pain management. So therefore, if we identify the problem earlier, and if you get patients in earlier and treat them correctly, then hopefully that the burden wouldn't be that much. So I think as caregivers, we need to identify that PKD is a problem and sort of appropriately send them on to specialists and get guidance very early in their management.
And Alister, a question from me would be, how does that referral get initiated? I guess in your experience, does it come from the person or does it come from the healthcare worker?
Or it can be from so any source, you know. So if the patients, like when it comes to pain referrals, all pain clinics, every pain clinic accepts patient referrals, but patients can get to the GP and voice their concerns that they have persistent pain and they need a referral to the pain clinic, and that's quite common. But the key is they need to have the pain for at least a period of 3 months before coming to see a pain specialist. Because most pathology, if they're going to become better, they would have got better in the first 3 months, assuming the healing process takes up to 4 to 6 weeks, you know. It's an arbitrary number, but you'd say that, okay, if there's any acute insult, it would heal within that 4 to 6 weeks period, or up to 12 weeks. But beyond that, if it persists, then you definitely, it's sort of appropriate to come to see a pain specialist.
Yeah.
If it's a patient, they can request the GP to send a referral. And every hospital has their own sort of triaging process for them. And at Westmead, all the referrals are triaged by a specialist where they look at the acuity of the problem. Say if you have a pain problem, which is quite early, so we try to get them in. If they're young, they have a recent problem, we try and triage them quickly, because the chances of them getting better is higher compared to someone who's had 20 years of back pain and is on a high dose of medications with multiple other psychiatric problems. So the outcomes aren't that great. So they still go on an elective waiting list, which is 6 to 8 months, you know. So triaging is done in each hospital has their own way. So the earlier, the younger, so we get them in earlier.
Yeah. Okay. Well, that's very useful to know. I'll keep going. I've got, as I said, just a couple of slides. Oops. Yes. So the causes of pain in polycystic kidney disease. Acute pain is really due to some complication with the cyst. Either the kidney cyst has bled or sometimes ruptured. Sometimes it can be a urinary tract infection, and kidney stones are increased. There's an increased risk of kidney stones in polycystic kidney disease. So these can cause usually acute pain. The chronic pain is usually due to the slow expansion of the cysts, and that tends to be the area where there's a lot of chronicity and difficulty in controlling pain. And there's different descriptions that people use, but the audience here today can tell us a little bit more about what they're experiencing. Often described as a steady nagging or dull pain or stabbing. It can get worse when with standing, walking, sitting, as well as pain that gets worse in taking a deep breath in. And interestingly, the pain from this chronic pain from a cyst doesn't really relate to the overall kidney size. It can occur with any kidney size, and it's really just due to the slow cyst growth. People can also experience a musculoskeletal lumbosacral back pain. due to a large kidney or liver, which leads to abnormal posture. And of course, there are other pains that people experience with polycystic kidney disease that aren't directly related to the kidney, but hernias are increased in frequency. Quite commonly, people experience bowel problems such as reflux, esophagitis, diverticulosis, and sometimes a large liver, when it gets very large, uncommonly can also cause pain. And as you said, Alistair, that cycle of pain progressively can lead to feeling anxious, depressed, having a reduced quality of life. So I think you really made a good point about how trying to arrest it and trying to deal with it earlier on is really, really important to stop that cycle. Did you have any other comments, Alistair?
Yeah, so in terms of the between acute and chronic, so we do see similar sort of patients who come into the hospital with, for example, patients with sickle cell disease. They have these acute episodes where they have hemarthrosis, or like in this case, cysts in the kidneys, which causes acute pain problem. During this period, we know it's going to be short lasting. It's going to be for a short period of time where the pain is going to be significant, and then it's going to become better with time. Yeah, and you go back to your baseline. But it is important to understand that during this period, there is a small proportion of patients who do get dependent on medications because they come to the hospital as an acute episode. They're given these high doses of opioids because during that period they need high doses of opioids, and that's the norm. They would be on PCAs, they would be on infusions of morphine-like medications. There are a small percentage of patients who tend to develop iatrogenic dependence or addiction disorders. So that's important to keep an eye on because around 14% of patients do get in trouble. Why it happens, we're not really clear about, because they can be genetically predisposed to that, or the psychosocial context is not conducive for them to sort of come off those medications. So that's one of the things in the acute phase. Whereas in chronic, in terms of the chronic pain situation, obviously we are trying to tease out and put patients into two major categories. One is it related to the kidney itself or visceral pain? So that's what we want to look at. And we want to look at putting another group of patients is it the abdominal wall pain. So these are the two first things. As a pain specialist, we go and say, okay, so this patient's coming with this tummy pains related, maybe is it from the organ itself or is it from the covering, which is the abdominal wall? Once we tease them out and design, it's basically from clinical examination and putting your imaging studies together. So once we know if it's visceral, the treatment is very different from what is for the abdominal wall or from the musculoskeletal system that you're talking about here. And the interesting part, which you mentioned about the size of the kidney, does not really have a correlation with the amount of pain. And that's an interesting part where when I was mentioning earlier that when people have repeated trauma to any particular part of the body, any part, it doesn't matter, the kidney or a limb or any part, the nervous system, two things happen. Your peripheral nervous system becomes sensitized and your central nervous system becomes sensitized, which meaning that for any given input, the output is exaggerated. So that's why you find that patients like this, with even small kidneys, cysts can have significant pain, whereas people with larger cysts have not much of pain. So there's no big relationship between that. And so if you find that, we'll always look for this. If any patient has a spinal pain, for the back pain is a common thing in this presentation. If the back pain isn't related to mechanical characteristics or movement related pain, if it doesn't happen, then you probably incline more to visceral pathology rather than musculoskeletal. So these are the things we're trying to give you an indication as what the mechanisms are behind the pain. Because if you know better what's the mechanisms related to the patient's pain, then you can target your treatment appropriately.
I think I've learned quite a lot in your conversation there. I was just wondering, Alistair, just one question that comes to mind, and I think we're going to cover this. But you were saying that the pain is treated differently if it's visceral as opposed to abdominal wall or spine, and how would that approach be different?
So if you're thinking about a visceral type pain usually presents with a vague sort of non-specific, because it's carried by your autonomic nervous system, or where I tell patients your automatic nervous system, but you don't have much control over. So it's generally a vague, it's very sort of non-specific, and you can't pinpoint it. Whereas the abdominal wall pain, it can be unilateral. It's usually sort of one side doesn't cross over to the other part of your body, and it can be easily provoked with like your carnage signs, and so like by clinical examination you can sort of provoke it. So for patients with visceral pain, you're trying to use basically non-opioid type medications. So non-opioid type like your gabapentinoids, your tricyclic antidepressants, your SNRIs, because you're trying to change the sort of central or the descending noxious inhibitory control. So it's more central. Whereas if it's a somatic type pain, they can be amenable to injections, so simple injections around, or we do nerve blocks of the abdominal wall. You can do TENS machine, TENS therapy, or acupuncture. All these things can be very helpful because it's more somatic.
Yeah.
The somatic pain, they also would respond to simple analgesics like paracetamol, anti-inflammatories if appropriate. Whereas the visceral pain, you need to look at the other type of medications. So treating visceral pain with opioids won't work. Whereas if you treat your abdominal wall pain with opioids, you have a better chance of better relief.
That's amazing. Yeah, that's great. So we'll probably actually gloss over the next few slides because you've answered some of them, but maybe we'll move on to the next section if I can get it going. So I think we were talking a lot about this that you pointed out, Alistair. So this is just to sort of explain a bit more about the origins of the pain and how the pain from the kidney gets communicated to the body. And Alistair, you're probably better at explaining this than me. So I guess our understanding is certainly that there's three routes where the pain can be received, and the organs themselves, the kidney and the liver, the ureter, where the urine comes out, and the tissue of the kidney itself, and the capsule of the kidney. And this was just a slide to summarize the different nerves that carry those pains, and also how those nerves then go back to the spinal cord and communicate to the skin. Alistair, as I said, you'll probably add a lot more sophistication to my discussion.
In the acute phase, I'm sure like we've all come across patients with renal colic. It's a very classical presentation, and in those circumstances, this all makes sense. You have a pain coming from the loin to the groin. It sort of makes sense in terms of the nociceptive type of characteristics. So nociceptive pain is where you have your nervous system is actually transmitting the appropriate information to your brain. So the hard wiring, which we know in terms of anatomical dissections, seem to be sort of perfect. So you have the renal patients presenting with loin to groin pain. So that's all good in the acute phase. But when you have a chronic pathology, all of this is irrelevant. It does not make any sense at all, because what happens from your studies in terms of functional MRI scanning and probably realize that there is no particular pattern at all when you have an ongoing sort of pain focus. Because what I explain to patients is like dropping an ink on a blotting paper. Everything becomes muddled up because the spinal cord, the segments, the adjacent segments become sensitized for that matter. And what maintains is it's your central supraspinal areas where your periaquital gray matter, and in the central cortex, the somatocentral cortex, that's what's driving the whole pain. So talking about the concept of central sensitization is important, because you find patients, they have a renal cyst, but the pain is everywhere. It's not to a particular dermatome or anything. So if you have anything in a proper dermatomal pattern, it's good news, because then it's probably earlier in the phase where the pathology. But once it becomes centralized, there's no real pattern. So you'll find patients, the whole abdominal pain, the whole spine. They might have a problem in the lower back, but they have pain going up to the cervical spine. So all those are signifying a process of central sensitization.
Right. Okay. So these diagrams here with the the nerve roots coming onto the dermatomes and supplying the skin area where people experience pain, more relevant to acute
On the earlier phases, it has an
stages.
acute pathology, but for chronic pain, it doesn't really matter that much.
And Alistair, that time period, is it 6 weeks, 12 weeks, 6 months, where that sort of central nervous system gets mixed
Yeah,
up?
no, it's based on the barrage of information getting into your spinal cord and the intensity and the duration.
Yep.
So you could, this, based on the definition, is 3 months. Yeah, so because most healing would have happened by that stage, but if it's going beyond the 3-month period, definitely there's a period. Most patients would have some central sensitivity, and that's why you find that simple interventions like trying them on anti-epileptic type medications or central acting medications like tricyclic antidepressants, very low doses, are quite effective at times. And that's the same basis for looking at top-down hypothesis, where you try and harness the descending noxious inhibitory control, where you're talking mindfulness, meditation, psychological interventions. You're trying to harness your body's sort of ability to provide pain relief, or your so-called endogenous opioid mechanisms.
So that's, again, a really important point. And a lot of what I'm presenting tonight is what's in our textbooks and our readings. So you've now explained this from a very different perspective. So I'm really grateful for that discussion. I'll try and keep the slides going because we want to get to your questions in the audience. Charmaine from PKD Australia really suggested a lot of, or suggested this, the content of this meeting, and really grateful for the feedback. And one of the advice Charmaine suggested was to ask a question about how to describe pain to a doctor. And these were the questions that, as a nephrologist, I'd be interested in. So where is the pain? When did the pain start? How often is the pain experienced? How severe is the pain? And what treatment do you take? And how does it affect you? Alistair, what questions would you want to know as a pain?
Oh, no, so it's a basic pain evaluation. So first thing is we're trying to get a pain story. The pain story is essentially where the pain is, how does it feel, and one of the important things which most physicians forget about, it's the descriptors of the pain, because that's so important in terms of diagnosis. Because if you look at how do you diagnose neuropathic pain or nerve pain, it's predominantly by the story. If you don't hear the story, then you probably miss out. So the pain story is so important in terms of what's the duration, how was the onset, what are the characteristics, and how the patient describe it, and what makes it better and worse. And those are the basic questions. But it's important to tease out, like try and find out what are the mechanisms behind it. And simplistically, you put them into two for patients. What I tell patients are the good type of pain, the bad pains. Good pains are the ones which make sense. When you're sort of your pain pathways are working appropriately. So whereas the bad pains are that don't make sense at all. And these are the nerve type pains. Sort of they have their mind of their own. I tell my patients that they are unprovoked. They have no sort of pattern at all. Generally, these nerve pains tend to become worse at nighttime. So having these information is very important to try and put them into these two groups, which is nociceptive type pain or sort of neuropathic type pain. And after that, what sort of treatments they've had, obviously, and what's worked. And it's also important to know what's not worked for them, and what current treatments they're on. And more important to see how that pain is affecting their function on a daily basis, because sometimes we might not be able to cure, if you like, their pain, but our sort of endpoints or goals would be how would we improve their function overall? Can we sort of make a breakthrough in terms of what their goals are and trying to work together with them? Because when it comes to persistent pain or chronic pain, sometimes we'll have to accept some of it and look at how to progress their function overall. And that's just the pain story, but then you have to look at always this is a very biomedical assessment of the pain, but the model of care for chronic pain is a biopsychosocial model. So you can have the same biological components in the patient, but a very different context. So you always ask the patient about their background in terms of what's the psychosocial context is very important, because you can have the same pathology presenting very differently when the psychosocial context is different.
I've just had a quick to Alister. Can you go back to the differentiation? So nociceptive and neuropathic. So nociceptive, how do you just define that, I guess?
Nociceptive pain is usually where your neural pathways are working appropriately. Patients usually describe it as a very localized, an ache, sore, mechanical in nature. Whereas neuropathic, they have these nerves-like symptoms like pins and needles, numbness, paresthesia, tingling. Usually there's a diurnal variation with neuropathic pain where it becomes worse at nighttime. Whereas nociceptive pain is predominantly mechanical in nature. Any turning, twisting, bending makes it worse. So it gives you some indication. And then the next step is, according to the criteria for diagnosis of neuropathic pain, is the first is the history. And the examination findings is if you have some positive or negative sensory findings on examination, whereas you find reduced sensation or heightened sensation, allodynia, hyperalgesia, all these symptoms, then you go on the third step where you do imaging to see if there's if you can explain that mechanism.
Yep.
So you put them into three categories: possible, probable, and definitive neuropathic pain. So that's the criteria. So if you just give a story, then you say possible. Probable, sorry, and then possible, and then if you have signs, then you say probable, and then if you have investigations which can tell you the mechanisms, then you say definitive neuropathic pain. Nociceptive is basically the normal pains which we have. And the best example in this case will be your renal calculi.
We've just got some feedback from a lot of the terms. Unfortunately, sorry, my apologies, that we've been talking about have been more medical terms, and it'd be good to hear them explained. So perhaps we could, we'll keep going, and we'll maybe just, because I think we've covered a lot of the aspects of the general treatment, so I won't go through these slides. And we might just skip these slides as well. I think we've already made the point about the big problem of chronic pain and its risk for anxiety and depression. So we can come back to this in discussion time. And really the last slide was just to, I think, mention a lot of the things we've already looked that we, as nephrologists, certainly have overlooked pain. Very important to bring up pain with your doctor and work out ways to manage it better. And I just want to finish with just saying that more research about pain is needed on how to sort of manage it and how to assess it. Just in light of that, I'm just wondering if Yong Ji Cho, who's an associate professor at Princess Alexandra Hospital, is online this evening. If not, Dr. Cho is a nephrologist who's leading an initiative in polycystic kidney disease called SONG PKD, and she will be holding a pain workshop in polycystic kidney disease on the 1st of October. And we would like you in the audience to express your, I guess, register for this workshop, because as you can see, we need to learn a lot more from you about how to manage this pain, as well as Alister. So I think this workshop is a more broader forum to discuss this in more detail and get your feedback into this. So this information that's listed on the slide, I'll leave it up for you, but Charmaine from PKD Australia will also advertise that on the website. So we might, if it's okay, just then focus on you and the audience, and just take questions from you. So maybe if I could start with Jay, is the early start? Oh yes, when is the early start? I'm 4 years into the first severe pain, 2 years on opioids after trying all others. Alister, if you're just hearing that someone's got a lot of pain, he's been suffering for 4 years. He had the first severe episode in 4 years ago, and he's been on opioids for 2 years. When would have been the time, or how could you manage that situation?
So in terms of the management of the current best evidence for patients with non-cancer pain management is essentially a non-opioid base. We try and stay away from opioids as far as we can, for multiple of reasons, you know. So if the three major side effects of long-term opioids is, number one is it causes hormonal suppression, the other one is immunosuppression, and the third one is osteoporosis. That's the main thing, the three main things. So when does this happen? It's usually after a 6 to 8 weeks period. You find that patients it starts off with you becoming very dependent on the medication. So the doses, you go back to the GPs, and the GPs, it has worked. So you say, okay, let's go up on the dose, and the dose keeps escalating and become higher doses. Once you go beyond a daily dosing of over 100 milligrams, what an interesting phenomenon happens where the very drug which is caused or giving you pain relief it'll start to create pain, and that's a phenomenon called as opioid-induced hyperalgesia. So it's a paradox. It becomes a big U-turn at the end. So opioids are good in the initial phase. Say if you have an acute event where you have a problem, so during that phase, it's quite worthwhile to trial them for a short period of time. And if you need it, you can take it in sort of bursts or pulses of where you have these acute flare-ups. But trying to be clear of opioid in between these flare-ups is very important, and especially for younger patients. For males, you get significant hormonal suppression where you have testosterone levels drop, and that's not only important for libido, but also for your general bone health, fatigue, and general mental health problems. You become very depressed if you have low testosterone levels. So in terms of opioids, you try and stay away from it. So if you have a problem where you have an abdominal wall problem, then it's maybe worthwhile considering at lower doses. What's recommended at a maximum dose for opioids is trying to keep it below a morphine equivalent dose of 40 milligrams a day. For example, all medications which are opioids, we convert them to an opioid equivalent in terms of morphine, be it tramadol, tapentadol, oxycodone, oxycontin, whatever medication, we convert it back to morphine. If the morphine is less than 40 milligrams and there's a genuine reason, then you can still sort of continue prescribing them as long as that's associated with functional gains. So it's important to say, okay, we know that the opioids cause all these problems where you become dependent, you tend to have problems with your hormones, you tend to have problems with your immune system, you have osteoporosis. Okay, this is a bad drug, but is that drug allowing you to function? So you have specific goals. Okay, I'm getting to work, I'm doing my stuff at home, I'm functioning well, and there are no other sort of concerns, then probably it's a good thing to continue opioids. But generally, we find that with research, and long-term opioids are always associated functional decline. So after, say, if I see in a month, I say around 80 patients overall, so only there'll be one patient of them who's actually benefited from the opioid medication. So we need to look at this harm minimization. So what are the risks versus benefit? If that medication is allowing you to function, then yes, you can justify it if there's no other sort of physical harm in terms of your serum testosterone levels are good, the osteoporosis is not that bad, so, or you not having any sort of chronic infection. So those are the things we look at.
So yeah, it's a very long answer to your question, but I think yeah, the long-term use of opioids is got a lot of side effects, as you were saying, Alister. So a couple of other questions. Will we be able to access this presentation after the session? And most definitely, Charmaine will make this presentation available. and we can also send a copy of the slides. Has a history of clinically diagnosed depression, anxiety, and OCD, and I've been phasing out of the pharmaceutical drugs in favour of high doses of quality bioavailable vitamins, minerals, and amino acids. I feel that I have occasional pain in my front upper right. Ultrasound only showed gallbladder sludge. If the pain is manageable, is it safe to continue the biomedical treatment? Could it possibly be irritating my cysts or possibly even speeding their growth or numbers? I read once that creatine monohydrate was shown to do this in rat trials. So in terms of the pain, I might defer that question to Alister, but in terms of answering the question about whether it could be irritating the cysts, generally when vitamins are applied in recommended doses, they will not cause or exacerbate, or not known to cause or exacerbate cyst growth. So the answer to that question would be probably no. With creatine monohydrate, I haven't seen that particular study in the rats, so my apologies, I'll have to read that before I can answer that question. But I wasn't aware of that causing increase in cyst growth. So, Alister, is there any evidence for biomedical treatment?
Sorry, could I just jump in too? I just wanted to say, I too noticed that when I took vitamins, I had this occasional stabbing pain in my kidneys as well. So I'm really interested, in this question.
So, I didn't know that. So, Charmaine, can you shed any more light on which particular vitamins or?
It was, so I was taking a pregnancy multivitamin and that was fine. And I think I switched to a women's multivitamin and it definitely had a different makeup. And I noticed I was getting more acute pain in my kidneys, although I feel it in my back. And when I stopped taking it, I noticed this went away. So I do wonder if some of the pain that I do experience correlates to when I am taking vitamins, or I suppose that's why I had the question on the dietary influences and pain too. So, and I'm sure it's not reported very often, because I mean, I wouldn't have mentioned this to my doctor and things like that.
I think that you make a really good point. There are things that are here to challenge doctors, because we think, like I guess you think of dogmas and standard thinking, and so we need to hear your views. Like I would never have thought vitamins could cause pain, so that's really interesting. And I think it might be something to talk through at the workshop, at the Song PKD workshop, because that's really interesting. Question: does draining the cysts help with localized pain? Generally, one of the problems with, if there's a dominant cyst, our interventional radiologist has suggested that it can help with localized pain, but the problem is that the cysts tend to grow again, and it's not a very common situation where you have a dominant cyst causing localized pain. So it may or may not help, and it would depend really on the size of the cyst or the particular situation. So in our centre at Westmead, our radiologist may identify a localised cyst by using an ultrasound probe to see if the pain's reproduced. And then if he or she is convinced about the cause of the pain, then it would be a trial of draining the cyst to see if it would help. Alister, I'd really be interested in your views on that.
Generally, my understanding is if there's a large cyst pressing on the nearby structures, then this is my anesthetic background. Sometimes you've had patients who they come for interventional radiology, they have to be put to sleep. So it's only for the ones who are very, very large cysts pressing on nearby structures, but otherwise, you tend to just monitor them.
And just going back to which we talked about the opioids just recently, the renal team has stopped doing anything more than monitoring and passing it to the pain team. the pain team has now put me on fentanyl and endone for the next 12 months.
Yeah, no, so these two medications are quite potent opioids. It's not a bad thing to be on opioids, but try and make sure you keep the smallest dose. When you have patients who are taking these medications, it's always important to see if we can opioid spare, meaning that trying to make sure that the doses are the smallest possible doses. So you use other medications which are known to spare the amount of opioids. So for example, if you need, say if your pain scores are about 8 to 10, 8 out of 10, and you need to take, be on a patch of, say for example, 25 microgram patch to bring it down from 8 to 6. So opioids pairing means you're taking other medications so you can reduce the amount of dose of your fentanyl patch. So if you add medications like simple analgesics like paracetamol, or you can use clonidine, or you can use gabapentin, or you can use tricyclic antidepressants, SNRIs. So all these medications are shown to reduce the amount of opioids which you would require. So if you have these as an adjuvant medication to your fentanyl patch or your endones, you'll find that you require far lesser doses. So what that would mean, you're lessening the risk of having complications from your opioids. Because if you look at the side effects, for example, gabapentin, which is a common drug which is used to opioid spare, there are hardly any organ dysfunctions which come out of gabapentin apart from mild sedation. Similar for paracetamol, if you do not go beyond the 4-gram mark, it virtually does not cause any sort of organ dysfunction. It's very, very safe. Clonidine, for that matter, an old-fashioned antidepressant, which can be used at very, very small doses to opioid spare. So the multiple adjuvants which can be used along with your opioid-based medication so that you decrease the burden in your system. So that'll be the main goal in terms of management. And obviously you have to look at the whole person. So medication is only one part, and whatever medication, even if you go on at the highest possible fentanyl patch dose, which I've seen patients having 150 mic patches of fentanyl, taking 60 milligrams of oxycodone. So whatever dose of these medications you take, the pain levels is going to drop only by 30% at best, or maybe 40% at 30. So that's the best outcomes, because all the research around these medications are reducing your pain by 50%. Yeah. So the rest of what are you going to do? You need to try and incorporate, okay, active self-management strategies, lifestyle modifications, diet, thinking about maybe meditation. All these things have to take into place. So physical reconditioning, so physical therapy interventions, exercises, diet, lifestyle, psychologist if you have significant mood disorder. And if patients are suicidal because the pain is too bad, they might need psychiatric input to look at medications to prevent them from harming themselves. So all these things need to be put in place. When it comes to medication only, the important thing is using multiple other medication at smaller dose so that you reduce the side effects of the medication, especially when it comes to kidney disease, when you rely on, many medications rely on the kidneys to be cleared. So therefore, smaller doses spaced out from working in different areas in your pain pathways is the best way in terms of pharmacotherapy or medication therapy.
We've got quite a few questions, and I'm hoping that we'll be able to get through most all of them. So ask the question that you've already answered, which is about the benefit of gabapentin. So just to summarize, adjuvant treatment with fewer side effects and would be preferred for the management of chronic pain.
Absolutely. That's good, very good drug. Was one of my first line medications, which I normally prescribe my patients. If they're not on dialysis, it depends on their kidney functions. The doses vary. For a normal individual, it goes up to 3,600 milligrams a day. Whereas somebody with mild to moderate impairment, you reduce it well below that. And if patients are on dialysis, then you need to keep it very small doses, up to 300 milligrams a day. Make sure you top it up after they get dialysis. So there's various varying regimes which you incorporate depending on the renal function. And it's a very safe drug to use.
Thank you for your presentation. I was reading about a Cochrane UK review that concludes that paracetamol is ineffective in back pain, acute or chronic. PKD patients are regularly told to take that and avoid non-steroidals. We need more intervention studies, and I totally very much so. So Alister, Can you tell us a little bit more about that?
Absolutely agree with that. If you think about back pain studies, so you got acute back pain and chronic back pain. So interestingly, they've tried every possible medication for acute back pain, which is back pain lasting below the 6 weeks mark, from paracetamol to non-steroidals, opioids, back schools, education, video presentations. So they've acupuncture, McKenzie exercises, it goes on and on, physiotherapy. There are only two positive in terms of randomized controlled trials. One is heat packs, and the other one is non-steroidal anti-inflammatories. So those for acute back pain. For chronic back pain, so rightly said, interventions are pretty good if you look at the outcomes in terms of research. Whereas for chronic back pain, medications usually are not effective at all. Whatever medications you take is still going to have a lot of back pain. And back pain is such a problem. There's 80% prevalence in the population. So treating chronic back pain is a very different thing. So medications do have a role. You try and keep it to simple medications. There's definitely no role for paracetamol in chronic pain. And so doctors are probably giving it because that's the simplest option, and they have to give you something in goodwill to take during your flare-up. Maybe that's worthwhile if it's all. But interventional options, as you brought up, it's quite good. There are multiple studies on radiofrequency therapies, and I was mentioning to Charmaine about spinal cord stimulation, neurostimulation. So there's multiple studies for that. The problem is you need to make sure you go through your step ladder. Make sure you finish your simple interventions first and then going into more complex interventions. So as far as intervention studies, radiofrequency neurotomies or axial back pain, and for patients who've had surgery and failed, or you have peripheral vascular disease and those sort of problems, neuromodulation is a valid option with lots of studies in that.
It's clear that we have a lot to learn. Has just got a comment about he had 1.2 litres removed from cysts, but it all returned inside 3 months. And yeah, I'm sorry to hear that. That would be the general experience, that cysts do tend to come back when you remove fluid. And the other interventions are sometimes problematic about putting other compounds to try and prevent the cysts from coming. They sometimes cause more side effects than good. A question or comment, I'm sure that diet affects pain, as my pain is at the front under my right side ribs, and if I eat out, I feel it the next day. Also carrying the weight increases pain. Alister, I wondered how.
Yeah, so there is some like indication that a diet would influence your pain. So they do say there is a pro-inflammatory response with the use of red meat. If you eat red meat, there's a pro-inflammatory response, and you can have flare-up of your pains. And that's one thing which I've heard of, but not really robust evidence for that. But in terms of your right upper quadrant pain and things like that, patients do have dyspeptic symptoms with the type of fat they take. If they have cholecystitis or sort of propensity to have cholecystitis or gallbladder issues, they do get worsening of the right upper quadrant pain with fatty foods. That's one of the possibilities.
Something we've noticed, in our clinic, almost quite a lot of people have complained of gastroesophageal reflux, as you mentioned, Alister. So I just was really surprised that so many people with PKD, or the people that I've met, have had that symptom. So I wonder if, as you say, it's a factor. And another question from anonymous attendee is, has there been any research done on the use of medicinal marijuana and the effects that it has on kidney pain? Are there any implications on kidney function using this medication type? So maybe I could answer just very briefly before handing over to Alister. So I looked this up yesterday because Charmaine mentioned to me that it's a very topical question. And unfortunately, in the setting of PKD, no studies that I could see that were done. So that, no, we're not, at least I'm not sure. In terms of kidney function, that's a really important point, because one of the things, I guess, about marijuana is that we're still learning, I guess, about the long-term effects. And basically, there's been some large studies, what we call cohort studies, where they've looked at thousands of people. For example, there's one called the NAME study that's tracked, I guess, a population group over a long period of time. And those type of studies don't show any adverse effects on kidney function. But there's also another study which suggests that there may be some effects on kidney function as well. So I think the short answer is that we don't know the answer to that. We need more research. There's also some literature about synthetic cannabinoids, which are related to marijuana, that they can sometimes cause injury to the kidney. But I think the short answer is that we're not sure about the long-term effects. Alister?
Yeah, no, definitely agree with that. And so we really don't know much about what's going to happen with cannabis, because majority of the use is driven by the community rather than the medical fraternity. So the research is yet to come out in terms of chronic non-cancer pain. I do prescribe medical marijuana as part of a study to patients who are generally more in terms of the palliative side of things, because about the age of 85 or that age group of patients, because it's more of comfort care rather than trying to, the goals are not to improve function or anything, it's just to try and reduce the pain levels. But definitely for younger group of patients, you wouldn't go down that route unless you're palliative.
Thanks, Alister. It mentions that gabapentin and other antidepressants have had a negative result and have unfortunately created anxiety.
Yeah, that's a common problem, because when the treatment for these non-opioid medications partly shows that we don't know ourselves at how chronic pain needs to be treated, because if you look at the underlying mechanism of chronic pain, we still do not know the underlying mechanisms to clearly understand why some people do get chronic pain and some don't. Yeah, so that's reflected on how we treat it also. The treatment of chronic pain, we have a few classes of medications. So we have tricyclics, SNRIs, SSRIs, gabapentinoids. You've got sort of anticonvulsants on the other end. You've got some atypical medications which we use. So all of these medications work on different parts on the nervous system or the pain pathways. So I tell my patients, all of them work at different areas, so we need to try one at a time. So when we start medications, you go by what's the level of evidence, and we talk about numbers needed to treat, which means the numbers needed to treat. I always give this example to my patient. For anesthesia, it's 1. So whenever I give a medication to a patient to bring them to sleep, all of them will go to sleep. That means the numbers needed to treat is 1. Whereas for pain medications, the numbers vary from 1 to 7. 1 is to 7. So I need to give the pain medication to 7 people for one of those 7 to get at least 50% reduction. So they're not very effective at all. So if you develop any undesirable side effect from a particular medication, it's not the end of the line. So you need to jump between the classes of these medications. If you try gabapentinoids, then you need maybe you can try pregabalin. If that didn't work, then you go on to a tricyclic. If that doesn't work, you go to an SNRI or an SSRI, or if you go to an anticonvulsant, or you go to atypical. So there are multiple medications which you need to try. And the key is you start on really, really small doses of medication and gradually up titrate them till you reach a stage where either you have good relief in pain symptoms or you develop side effects. And then you come back if you have side effects, and keep it on that dose, which is tolerated for at least 4 to 6 weeks. And that's a trial, that's a proper trial. So you start low, go to the maximum tolerated dose, and keep that for 4 to 6 weeks. And that's when you make an assessment that these medication worked or not, because many a times I see patients come to me and say, oh, I've tried every possible medication, didn't work. When you ask them, they were taken for 3 or 4 days. So these medications are very, very lazy drugs. They take a long time to work. So it's not like your endone or a fentanyl patch or a nosepam patch where you find the effect straight away. The analgesic effect for all these opioid medications they start within a few hours. So if you take an endone, within 15, 20 minutes, it's going to work. if you put on a nose span patch, it's going to work in 6 to 8 hours. So you need to give these drugs are very slow because the mechanism action is more central, and you need to change that chemical soup around the nerves, and that's how they work. So you need to give that 4 to 6 weeks time for these medications to be effective. So if one class of medication didn't work, it's always good, worthwhile investment in another one. And there are newer medications which are shown to be quite promising for pain in terms of neuropathic pain.
So Alister, the answer is don't give up. There's still a lot more to try, and it takes a while to for them to work. So the other question are there any anti-inflammatories worthwhile when kidney function is low in state, like for example GFR of less than 30, Alister? I guess my feeling has always been that in short-term use it can be used. It's a critical question, I guess, is whether you would use whether there are other non-steroidals or COX-2 inhibitors or some other compounds that can be used. That's no. So I think the short answer would be that there isn't any worthwhile ones at sort of a lower level of kidney function. And just from anonymous attendee again, this may be a trivial condition in comparison to others. I'm sure it's not. I'm not, and I've been told to ignore, but I'm not going to ignore. But reflux is a common problem for many of us. And so I'm glad you mentioned that, because I've also noticed that as well. There is concern for some of us that the medication we use to control the problem should only be used for short term. So I guess I'm thinking about things like pantoprazole or Somac. You might be referring to the anti-ulcer medications. I would say, just in answer to that question, the long-term use of proton pump inhibitors, it's there was an association with a type of kidney problem called interstitial nephritis, but it's so rare. It's almost like a 1 in a million problem. So I think if it improves your well-being and your quality of life, there shouldn't be a problem with using it in the long term. Also, yeah, is there a concern with medications such as Nexium, which is a proton pump inhibitor? So long-term use, if there's reason for using it, there isn't a concern from the kidney viewpoint. Finding an alternative is a real process and can be very uncomfortable. So I think the short answer is it's okay to stay on Nexium in consultation with your doctor, and if it's helping you, the risk of any kidney problems is really a very, very small risk. It's about 1 in a million. And yes, regarding reflux, it'd be great to know more links about this between gastritis and PKD. I totally agree with you. Almost every week when we're, our team is talking about who we've seen in clinic, reflux comes up in almost every person. So we've been wondering the same thing, and I think more research needs to be done. And so agrees. She also mentioned that she gets reflux, so for sharing that. Also says thank you, and Vin said, reflux medications comment short-term use. Yes, thanks for answering this. Okay. Sorry, I've probably gone through those questions quickly. Charmaine, did you want to say anything? How much more time do we have?
Yeah, look, we do have another question. I've been told no NSAIDs at all.
Oh, yes.
Even short term for sporting, it just popped up, yeah. Even short term for sporting injuries, and even with early stage PKD.
So I think it depends a lot on the situation. So I think there isn't really any specific guidelines on this, and I think that's what makes it difficult about approaching this problem, because all the guidelines that doctors look at will be say no non-steroidals at all. And I guess you could sort of say exposure sort of repeatedly might be an issue. But generally like I guess if you speak to most nephrologists, a short-term use is okay, like for 3 days, and not repeated frequently. So it would really be sort of at the discretion about if that pain approach is the best one. And I would think that short-term use wouldn't be detrimental, you know, for a couple of days. Alister, any additional?
You go based on the renal function, and during the patient with, if the renal functions is okay, so usually short-term use shouldn't be a problem.
Yeah.
I might just ask a question or share an experience just about when pain can be a symptom of a cyst, something more serious going on. So how to really tell the difference. So one stage in my life, I had very severe kidney pain, and I just put this down to having polycystic kidney disease. And it turned out I had an infection in one of my cysts. So do you have any comment on what I could have done better next time?
I don't think there's, like, I think seeking attention, and I think as Alister mentioned, the history and telling the story and the doctor listening or the healthcare worker listening to your story is really important. Because I find this quite amazing now, because when I was going through medicine, I was just taught to listen, take a history, do an examination, but that art seems to be disappearing a bit more these days. And I don't think you could have done anything differently except to tell your story and for that diagnosis to be made. Sometimes it can be difficult to make the diagnosis of a cyst infection because the symptoms are very non-specific. And sometimes you might not get all the features that people are looking for, like fever or a blood test that shows an elevated white cell count. So it can be really difficult because the symptoms are really just not specific. I've actually seen.
Yeah, it was only until they did an ultrasound that they found the cyst was infected. So it was a long process to get the diagnosis.
Your story is probably not unusual because it is we're often thinking of the acute pain in the abdomen, but we're not putting, like, it sometimes can be very difficult to put those non-specific symptoms into a diagnosis. So I agree. I think that's a really important thing to share with everyone online, that cyst infection can be really hard to diagnose. And so my thinking would be that it's something to just say to your doctor, do you think I've got a cyst infection? Just to trigger that thought process. Please share whatever you're thinking with your doctor. Alister, how would you approach that? Any other comments?
Yeah, I think the first thing is if it's something new, because most patients with or chronic pain would know what their usual pain feels like and what a normal exacerbation. So when you have persistent pain, you're going to have this. Most patients have a background pain level, and then they have these flare-ups which come in and out. So you'll have ups and downs throughout. You know, that's the nature of chronic pain. And most patients would sort of be able to differentiate between what's their usual flare-up versus what's something not right. And when you get that thing of something not right, that's when you definitely need to go and check up. So a simple scan would be all that's required. So we have patients who come to ED who've had 16 presentations, 20 presentations in a year. So not for this problem, but generally for other abdominal pain problems. So the first thing is, okay, if it's something new, something out of the way, which you think it's sinister going on to you, it's a matter of just getting an ultrasound, a simple sort of scan or a CT quickly, to at least reassure, because it's better to have a simple scan and rule out something sinister rather than having it to become worse and then having renal failure. So most patients will have that feeling, okay, this is not my usual flare-up, and that's when you need to be definitely checked up.
Was there anything, Charmaine, that triggered that thought process? Was it just people just thought we better check?
I was very young, so I was a teenager. So, you know, you try, like at least I did. I pushed any issues aside and sort of tried to ignore them. And growing up, like I've learned to advocate for my health more and not ignore symptoms as much. But you know, it's difficult when you're so busy sometimes.
And also when you're young, like if you're young, you're not likely to question things. And yeah, so thanks for sharing that. That's really important. I've got a couple of other questions. So how can you tell if the pain is caused by PKD or something else? And I think that's a tough question to answer, mainly because I was thinking of Alister's comment about in chronic pain, the pain can be anywhere, as you were saying. And also I think that musculoskeletal pain that sometimes you can get with large kidneys, hernia, diverticulosis, reflux, it's all mixed up. So my simple view would be taking a history and examination, and then going along those suspicions. But Alister, what are your thoughts? Is there something that a person with PKD could tell themselves?
Absolutely. So you go by first principles in terms of taking a proper history and examining, and that'll guide you in terms of what's going to happen, what are you going to come out the other end. You know, sometimes you might not need an investigation, but it's all about doing a proper evaluation. Yeah, and the GP should be able to do that.
I guess from perspective, as a person who's got that symptom, I guess I would imagine that you would also have had experience about what you felt before as well, and associating those pains with those causes can sometimes help, I suppose, as well. Got a question, which is what Charmaine's also touched on, which is about getting your healthcare worker to know about PKD and the problems. And I think my feeling would be just to really approach a doctor that you have a relationship with, that you're comfortable with, that listens to you. That would be the most important. And if you feel everyone's got a different personality, so it's just that sometimes the two personalities, healthcare worker and the person with the problem, just might not be able to work together. So it's nothing personal. You just have to change your healthcare worker, I guess, or your GP as someone that's going to listen and take an interest, and someone that's going to be watching out for you, like the most important, someone that cares about you, I think. I think, is there any other questions, Charmaine?
No, that's all the questions. Oh, just a comment from JP is great. The issues I've had is with local special services, lack of knowledge of PKD.
Yes, and I think the same thing I'd probably say. Alister, I'm not sure what you would say there. I think the main thing would be to try to ensure that you're understood, you're listened to, and that you're taken care of. That'd be the most important thing. Charmaine, do you have any other feedback for John?
I think a lot of people with PKD do find that in the medical system, there will be people that don't know a lot about PKD, and and she's had some poor suggestions from her GPs, and this is something that we'd love to improve through GP training and really raising the awareness of PKD, which is a mission of PKD Australia, trying to raise the profile of this disease so that more people understand and are aware of it.
Charmaine, a few years ago, and I haven't done these for a while, but we used to have workshops for the general practitioners through Kidney Health Australia. We used to run through the, they had a conference at the showground here in Sydney, and PKD, Kidney Health Australia had a series of slides. It was actually quite a useful session. I'm not quite sure if they're still ongoing, but I'm not sure if that's a way to approach this problem, or whether it's a problem that's more local within certain cities, or
we do see differences between different areas, different sort of ways that GPs are referring their patients to nephrologists, and different awareness about the treatments of PKD, and certainly this is something that PKD Australia is discussing, and and potentially partnering in the future with KHA to find out how we can address this further.
Great, that sounds good. And a question from the found an excellent pharmacist who has been very helpful. That's fantastic, and always checks if medications are suitable for the with PKD. So I think that that's something that you brought up also, Charmaine, before we started, about the importance of a multidisciplinary team in sort of being involved. So in healthcare, we often talk about the Swiss cheese model because, you know, if there's something that's missed by one person or one part of the system, then another person will pick up that problem and address it. So the problem doesn't sort of end up going through the, we call it a Swiss cheese model. So I think it's good that you found a pharmacist to engage with you, because it really doesn't, at the end of the day, it doesn't matter as long as you get the information that you need and that someone's caring for you. And lastly, asks, can ultrasound miss specific cysts causing pain? My last ultrasound technician had never seen PKD before and couldn't count them. So I think the short answer would be most definitely. So our radiologist, our expert radiologist at Westmead, Simon Grunwald, who's been doing ultrasounds for probably 30 years, I think. And he's, you know, I guess he would say to you, most definitely, it can be very difficult to miss specific cysts causing pain because there is a lot of them, and trying to identify which one could be causing pain is actually can be quite challenging. Alister, any other comments about that?
Yeah, no, so just a general comment. And ultrasound depends on the user. It's user dependent. So, yeah, so you have ultrasonographers who miss a lot of things. So better, if your ultrasound does not show up anything and you still think there's a cause, like I'm not talking about the kidneys and specifically, but in general, ultrasounds are non-specific, and if it depends on the user. If you still have a suspicion, it's better to have a CT or an MRI scan.
Yep, totally agree. If liver cysts can cause pain. So liver cysts are very common in PKD. Close to 80% of people have liver cysts. Now, the general teaching is that liver cysts, when they're very small, don't cause pain, but it generally tends to be when they're larger. So it probably doesn't answer your question completely, but I would be erring on the side of saying that, you know, a lot of people have cysts and they tend to be, they don't cause symptoms mostly, unless they're very large. Alister, any final comments? Thank you for being involved in this webinar today. Did you have any other? I've taken down a lot of notes that you've made.
The only thing which I would say is like it's chronic pain is a lifelong problem, and it's you should look at it as a chronic illness rather than just pain, because chronic pain is a disease in its own right. There's lots of, not only the structural problem that you have, there's lots of central changes within the brain which happens over time. So it's a disease similar to diabetes or hypertension or whatever chronic illness which needs to be managed. And the best management approach for chronic pain is looking at the biopsychosocial model, where the doctors do the physical sort of parts, or looking at the biomedical aspects of the pain, where trying to explain the pain mechanisms, giving medications, and that's only one part of the problem. So the other thing is physical rehabilitation, making sure you have reasonable fitness, and then your mental health in terms of meditation, mindfulness, and obviously to put all this together, it's your lifestyle modification. So lifestyle modification is obviously you're trying to see if smoking cessation, alcohol intake, drug use, and all these things, you know, so lifestyle in terms of diet, weight management, all this needs to be part of it. It's not just like if you have pain, you take the medication, it's going to become better. So it's incorporate all aspects in terms of mental health, your physical health, your doctor appointments, maintaining sort of a good relationship with your treating professionals. If you don't get along with them, you just need to change straight away. Because I see a lot of pain patients come to me and say, okay, my GP doesn't understand me. I said, please do change your GP straight away, because he's the most important healthcare professional which you need to follow up on a regular basis. If you don't have good relationship with your GP, it's time to change it then and there. There's so many GPs around. So getting a good GP is hard, but it's worth trialing a couple of before settling down.
Yeah.
Because they're the ones who are going to liaise with not only your physiotherapist, your psychologist, your specialist. And if you don't have a good one, you're not going anywhere. It's very hard.
I think I just want to emphasize what you said. So the general lifestyle aspects are really critical, because you were saying before that the opioids really only dampen the pain by 30%, so it's really more of a broader approach that you need. Yeah. Okay, well, I think, Charmaine, do you think there are any other comments or feedback, or should we close the meeting?
Yes, thank you, Gopi, and thank you, Alister, for your expertise in this area. And thank you, everyone, for joining and listening in.